Despite all of this, despite the plethora of information, when it comes to patients being diagnosed with a disease as serious as cancer, confusion instills and everybody gets overwhelmed, whether you're a patient or a family member.
Welcome to Mind, Body, Health, and Politics. I'm your host, Dr. Richard Lewis Miller. The mission of Mind, Body, Health, and Politics is to enhance your physical and emotional well-being and encourage community. I say encourage community because I believe that human beings are basically tribal animals, and I believe we do the best in terms of collaboration and sustaining one another in our lives when we live tribally in small groups where we know each other either by name or at minimum by face. So give consideration to what you think about tribal living, small groups of people associating together. Typically on this internet radio broadcast, Mind, Body, Health, and Politics, I go right to the podcast without introducing the guest. Whereas when I used to be on the radio, as you recall, there were lengthy introductions of the guest. But today I'm going to give you a brief introduction because Dr. Chadi Nabhan is a very distinguished clinician. And I want you to know that he has written, or actually he has authored or co-authored over 300 articles and abstracts. Now that's quite a performance, in addition to his practice, in addition to his podcast, which he's going to tell you about. So I bring you today with great privilege a man who's really on top of his field. Welcome to Mind, Body, Health, and Politics, Chadi.
Richard, thank you. This is a very kind introduction. I don't think I deserve it, but I appreciate your generosity and your introduction. Thank you for having me on.
With due respect, sir, I'm not being generous. I'm just calling it as I see it, and I love your contribution. That's why you're here. So, Chadi, you wrote this book, which I'm going to put on the screen. Here it is for everybody to see. And in this book, you distill at least 20 years of your practice as a hematologist and as a medical oncologist. And so today, we have a limited amount of time for you to tell us, to distill for us what you put in this book. So let's take it from the top. What do we want our listeners to know about the possibility of getting cancer and what to do when they're diagnosed with cancer?
It's a short question, and the answer obviously is very lengthy, but maybe I'll take it one step back and I'll tell your audience is that there's no shortage of platforms to gather information and find information. You'll go on the World Wide Web and you'll find a lot of information. You'll go on social media, Twitter, all of these things, and you'll find a lot of information. Despite all of this, despite the plethora of information, when it comes to patients being diagnosed with a disease as serious as cancer, confusion instills and everybody gets overwhelmed, whether you're a patient or a family member. And you don't need Chadi Nabhan to go on Google and say, what is breast cancer or colon cancer, or things like that. But despite the availability of this, patients and families struggle separating signal from noise. How much of what I read is real? How much what I read is not real? And what am I going to do next? I saw this in my clinic day in and day out. I saw this from the top educated folks who could be physicians, CEOs, and the alike. And I saw this with folks who are completely not educated, who I cared for. So what I wanted to do, I wanted to take all of this and really provide something that is very easy to read for anyone who is affected by cancer. You do not need to have cancer to be affected by it. You could be a caregiver. You could be a dear friend for somebody. You could be a neighbor, a colleague. You could be a primary care physician who have cared for somebody for 20 years and now your patient has cancer, but you need to be able to be well-versed in advising them before they see the medical oncologist. So anybody who's been touched with cancer, I hope that this book provides this guide to get them through that journey, the unfortunate journey, as they are diagnosed. I guess I know you're going to ask me a lot of questions, so I don't want to take a lot of time answering the first question, but a couple of things come to mind that may be worth mentioning from at the top. Number one, I want folks to realize that cancer is not one disease. It's just not one disease. One of the most common questions I get asked is, when are you guys going to cure cancer? And I don't think it's a fair question because many cancers are cured, many cancers are curable. At the same time, some cancers are not. So they're not equal, and we can't really ask that question in general. So I wanted to explain that cancer is not one disease. There are many diseases all under one umbrella. So my goal was to simplify this. And the second large point I wanted to make is that we have made so much progress in how we treat cancer, how we understand cancer. And hopefully this book provides a lot of positive view into the world of oncology. And since you read the book, obviously, Richard, you know it's storytelling. I mean, I like to tell stories. I like to share stories with readers about things I've encountered in clinic, because the last thing you want is another textbook. It's gonna, in my opinion, is gonna make things boring, and I think people will not be engaged. So I wanted to use my ability to tell stories so I can convey the message to the readers.
Well, that's excellent, and that's what makes the book, for the most part, very readable. There is a technical material in the book that most people,
Yes.
they're going to have, but I'm glad for those of us who want to know about the molecular biology and some of the other aspects, good for you for putting it in, but you didn't overdo it.
I mean, I try, but I really thought I tried, because believe me, every single chapter I wrote, I read and read again. And sometimes I even read it to friends of mine who are not in medicine, because I wanted to pressure test whether the information is digestible or not. No question, I think there's probably some material that would be a little bit not as easy as others. But even when I talked about the DNA and the RNA and things like that, and about the cells that are growing in cancer, I tried to bring this back to like a building. You have a building, the building is composed of bricks, and these bricks you have wear and tear. And I tried to explain that this building is your organ, these bricks are the cells, and the cells sometimes usually wear and tear, and our body repairs them. So when the body is unable to repair them, that's when things go out of whack. So I tried to bring things in a different way where if you're reading it, you can try to probably understand it in an easier manner. I hope I was successful. I'm sure there's always room for improvement, as I always tell people.
Okay, let's get to some headlines in the book. We won't get into every page. To begin with, at what age should people start looking for the possibility of cancer if they want to be involved with early detection? When should people start bringing this into their radar screen?
Yeah. So early detection, what you're referring to, Richard, is obviously screening. Basically, this is a situation where the person is healthy, completely healthy. They have no symptoms to suggest they have a disease. They have no signs to suggest that they have a disease, but you are looking for the possibility of them having that disease early on. The idea of screening is, if I detect the cancer at an early stage, then I have a higher chance of curing it and getting rid of it. The answer to your question is, unfortunately, it depends. It depends on the person, their family history, and the cancer that we are looking for, and the test, the probability that the test could detect something. I don't want to belabor the point. I'm going to give you a couple of examples, and I do actually provide that in the book in the entire chapter called Screening for Cancer. It's the second
Yes, you
chapter.
do.
So, simple example, let's talk about breast cancer. In general, women are advised to undergo breast cancer screening with mammography. And most authorities say after the age of 50. Some folks start at the age of 40, it depends. And however, I can tell you that in certain situations, where a woman has had prior radiation therapy to the chest for whatever reason, that might increase the risk of developing breast cancer early on. So the advice is to have it earlier than 40 or 50. Even if you were 20 years old, as an example, you will need to do that if you've had prior radiation to the chest. There are women who have the BRCA1 mutation. This is a mutation that increases the risk of breast cancer and ovarian cancer. And these women need to undergo screening. And sometimes the screening is not mammography, it's an MRI of the breast, because it turns out that for women with BRCA1 mutation, MRIs add a lot to mammography. That's one example. I'll give you the other example of colonoscopies. Colonoscopies usually today are recommended for people over the age of 45 and above. Having said that, if, for example, a patient has a strong family history of colon cancer, or they have a gene that is mutated and has led to the development of colon cancer, then they may need to be screened earlier on. So it depends. So I think every individual should ask their primary care physician about your question. It's a very important question. And the doctor, to answer the question, needs to spend some time understanding the family history of that individual, the values of that individual. Is that individual somebody who wants everything done and screened and all of that stuff? And the last comment I have, and sorry to be very verbose, but your question obviously is very broad, is we have to worry about something called overdiagnosis. What does that mean? It means if you're screening a lot of people, at some point you are going to detect something that is probably was not going to cause any problem whatsoever. So all of a sudden you diagnose this disease in this individual who was not going to have any problems, and now you may do treatment, and that treatment could be worse than the disease that was not causing any trouble. A perfect example of this is prostate cancer. PSA is always used to detect prostate cancer, but if you have a high PSA and there is prostate cancer, sometimes this prostate cancer may not cause any trouble. So did we do a favor by diagnosing that individual with prostate cancer, or did we overtreat and cause some complications and things like this? It's a very, very, very important question. It's challenging to answer. There are many books written about it, but I would say the take-home message, number one, ask your doctor, give them the family history, and it depends. They will decide whether a test is good for you. Number two, in life and in medicine, there are trade-offs. Unfortunately, always trade-offs. If you do a test that's going to detect something, we have to be careful. Are we diagnosing something that was never going to cause trouble, and is our intervention going to cause a problem? So I go through all of this in the book, as you read, Richard.
So you say you like to teach through stories. So I'm going to, during this interview, tell you 3 stories from my personal life having to do with cancer. One has to do with my wife, who, as I told you prior to the beginning of our interview, sometime after we set up and scheduled our interview, my wife was diagnosed with lobular breast cancer. She had been taking a mammogram every single year, and it was always negative. This year, a nurse in the doctor's office said to her, you know, maybe you ought to also get an ultrasound just to be safe. So my wife got the ultrasound, and there it was, cancer. So I did some research on this, and I found that, yes, I was right originally in believing that the mammogram was the gold standard for early detection, but I also found that when you have what you guys referred to as dense breast tissue,
right,
you really ought to get an ultrasound also. Would you comment on that, please?
Yes, I mean, I think it's not unusual to be faced with the dense breast tissue. My comment on that is in general, you should be able to tell if the tissue of the breast is dense by visualizing the mammogram findings and by physical exam when you examine the breasts. And I tend to agree. In a dense breast tissue, sometimes the mammography is not actually enough, the traditional mammography. There are different advances, there are various advances in that field right now. One of them is the 3D or tomosynthesis, where you actually are doing more like mammography on steroids. You're able to actually see more angles and more areas, and I think that's really important. There are times when you have the dense tissue of the breast, you actually do even MRIs of the breasts if the tissue of the breast is very dense. And the other time also you do ultrasound. I think the ultrasound plus the mammogram is obviously better than the mammogram alone in that situation. So I tend to agree that this is a good approach to do that in certain scenarios. And that's why, honestly, it's very difficult to standardize everything. You have to individualize the approach, whether it is treatment or even diagnostic tests.
You know, my wife was very disappointed when her new surgeon down at Stanford, Dr. Fred Durbus, said to her the other day, "You've probably had this cancer for 4 or 5 years." And she's thinking, oh my gosh, I did what I was told. I took the mammogram every year. Nobody ever told me to take a second test. Don't I wish somebody had mentioned it so that I would have caught this cancer earlier? In fact, maybe I would have caught it before it made its way to the lymph nodes. So
Now,
I'm
why
wondering,
did he think it would have been earlier? Like, what was the
why did
what
he
were the
why did
important?
he why did he say that to her? I don't
Yeah.
know the answer to that. It's a good question. We can ask him. But what I'm leading up to is, should people listening to this program, particularly the women listening to this program, or men who want to talk to the women that they're in a partnership with a woman, should they be talking to their doctors and saying, by the way, in addition to a mammogram, should I get an ultrasound to be safe? Because I heard this story about a woman who got a mammograms and it didn't show, and then the ultrasound showed it.
Yes. The way I would ask the question, though, is I wouldn't necessarily suggest the test. I think the proper question is to the doctor, should I do any additional test beyond the mammogram that might help detecting something that the mammogram may miss? Because, as I said, sometimes an MRI is better, sometimes an ultrasound,
Okay.
and things like that. But I think it's a very fair question. I think that, like I said, there are different newer types of mammography that get done right now, not the plain old mammography. And frankly, if pretty much mostly anybody who is now goes to an academic medical center or large healthcare system will probably have the advanced way of mammography. I don't
I
think it's going to be
see.
the old way.
So there's
I don't
different
think so. I mean,
mammographies.
yeah, there's like the we call it tomosynthesis.
I
So I
understand.
yeah, but it's a very good question. I think people should ask. And you know what? Since you mentioned it, I go extensively in the book about sometimes how people feel uncomfortable asking all of the questions. I think that there is a sense of fear that, well, am I being a burdensome on my doctor or my nurse? Am I
Yes.
being too
Yes.
and I think that we should really step out of this and realize this is your life, your health. You must ask all of the questions that you want. And sure, and especially in the first visit. But even in subsequent visits, if the doctor is too busy to answer all of your questions during a follow up visit, because the follow up visit may be 15 to 20 minutes, then they will say, you know what, I will call you back and address all of your questions, but let me address your top 3 or 4 while I'm seeing you. Bottom line is, do not be shy asking questions. Just do not be shy asking questions.
I want to underline what Chadi just said to everybody listening, because as a clinician, I agree with him 100%. Doctors are often seen as gods or demigods, and there's a lot of fear about asking them questions. And what he is suggesting, and I am advocating for as well, is that we have to get over that. We have to have a new paradigm. You might want to bring an advocate in with you, which I always recommend, so that you can ask the questions that are on your heart and soul when you're dealing with something that's so serious. And on page 108 of his book, 108 of his book, he gives questions that you can ask the doctor. He offers a very comprehensive list of questions. And I highly recommend that you look at that list on page 108 if you're dealing with this. Now, I said I was going to talk about 3 examples. I gave one example of my wife. Now I'm going to give an example of myself. We'll move on to colorectal cancer, which I haven't had. So some years ago, I saw an article in the paper, and it said the President of the United States had a colonoscopy. They found 2 benign polyps, and they are going to do another colonoscopy in 1 year. In my lifetime, every time I've had a colonoscopy, my doctor says, I'll see you in 5 years. So the next time I went for a colonoscopy, my specialist, who I've gone to for years, who's now retired, Dr. David Watts at UC Medical, a wonderful guy and a poet and a writer. I said, David, I want let's see what you find. And by the way, you're going to get a kick out of this, Chadri. I don't take any anesthesia when they do the colonoscopy.
Oh, you're a brave man.
No, I just do I'm a master at abdominal breathing. I keep myself totally still for David, and I watch the procedure on the television, and then he gives me a lecture on what he sees. So I learn about what's going on, what he's looking for. I watch the scope go inside my colon.
I just tell them, drug me up. I just want to sleep. Just drug me up.
That's what most people do. Well, anyway, this time, he's going in and he says, oh, there's a polyp. And he shows me the polyp and he snips it off. And then he shows me how he snips it off. And then he finds another polyp and he snips it off. And they were both benign. So I said, David, if the President of the United States finds 2 polyps that are benign and gets another colonoscopy in 1 year, I want another colonoscopy in 1 year. Now, what are your thoughts on that?
I don't think the president needed to have another one in 1 year, but maybe presidents get special treatment. Look,
well, of course. But tell us about the polyps
I think it depends on what the polyp looks like. So, for example, if they're completely benign and they're what we call just hyperplastic, which means they just look normal, most often you just don't need really anything for like 5 years, even plus. There are different types of polyps that may look a little bit bigger. They like adenomas, or like depending on the cells that you see on it. Because once you remove the polyp, you look at it under the microscope and you see the type of cells that you actually removed. So the way we look at colonoscopies is as follows. If you see nothing in the colon whatsoever and everything is fine and looks good, usually you don't need to repeat it for another 10 years. As long as the person is healthy and not having symptoms. And in fact, I go in the book. So when a doctor tells you don't need to come back for 10 years, they're assuming that you're going to be feeling well during that time. But if you start having symptoms, then you may need to have some testing before these 10 years. You have to remember that screening is looking for a test in people who have no symptoms and no signs and they're feeling fine. But if you don't feel fine or you have symptoms, it's no longer screening. It is diagnostic. And I probably was very redundant with this because I said that like many times, because I really feel strongly about this. I think that a lot of people assume that he told me I go for 5 years or 6 years. Yes, as long as you're feeling well. But in that interim, if you're not feeling well, then you need to actually seek attention and important. And actually, what in page 25, Richard, if you allow me, it's a very small paragraph, but it's so important. Page 25, under screening for colorectal cancer, the second paragraph, it says, it is essential to re-emphasize here that screening means doing the test on someone who has no symptoms or abnormal physical exam findings. If unusual symptoms or findings emerge, the test might need to be performed sooner after consulting with the physician. That's really key. And I mean, it breaks my heart to tell you that I've seen patients who presented with a newly diagnosed of colon cancer and would tell me, well, I saw the doctor 3 years ago, I did a colonoscopy, everything was fine. So when they saw blood in the stool or something abnormal, they did not think of it anything because they just had a colonoscopy that was fine. I'm like, he told you it's fine, but if you develop something, you need to seek medical attention. So the short answer is, unless there's something unusual that was found in a colonoscopy with a polyp, or unless there's a particular mutation or a hereditary type of things, or yearly colonoscopies are extremely unusual. We do them every so often, but in very rare certain circumstances, which I don't believe any president has had, at least in my lifetime. Most often, you do the colonoscopies either every 10 years, if you have no issues, or every 3 to 5 years if they find some polyps, depending on the type of the polyp.
One of the questions that you ask, or you suggest that people ask their doctor on page 108 of your book, is how much experience do you have at this particular kind of procedure? And I think that's a tough question for a lot of people to ask their doctor, but I think it's a very good one. And I'll give you an example from my own life. I recently decided to do a prostatectomy voluntarily. I did not have prostate cancer. What I had was a very large prostate. I mean, it was 134 grams, which you know what that means. It's very large.
Right.
And it was so large that it was pressing on not just on my urethra, it was also pressing on my bladder. So I started, and I was lucky because I was still urinating, but I was urinating quite frequently. And I decided to do a preventive strike and take the prostate out rather than wait for some time in the middle of the night when suddenly I can't urinate and I've got to go to the emergency room to get catheterized. I didn't want to deal with that. And I also was told there was potential danger to my bladder of having the prostate push on it. So I didn't know how much danger, but I decided to do it. Now, almost everybody I know, since I'm 85 and I've got tons of friends who have had prostate issues, because I think it's the number one form of cancer in males in this country. Am I correct? Prostate cancer?
In terms of being diagnosed, yes.
Yeah. So almost everyone that I talked to had problems. Either they had to go back to the hospital or they had problems afterwards. A lot of problems, even with the robotics. So I did some research because I'm like you, I'm a researcher, and I found out about something that I know you know about, which is radio frequency, a laser of the prostate, where there's no incision, and you go in through the penis. And I also was told that there weren't that many people in the United States who did it, and if I found someone, I should ask them how many he's done, and if they haven't done 50, I should find somebody else. So these are what the tom-toms are telling me. So I found a great doctor, Dr. Thomas Chi at UC Medical, who had done many more than 50, and he performed a laser prostatectomy in through the penis, no incisions. He did the surgery in the morning. I left in the afternoon. Actually, I inadvertently went to a party that night, and because the place where I was staying, they were throwing a party, and so I walked right in. But what I'm leading up to is there was no after effect. I peed blood for a certain number of days, decreased over time, and that was the end of it. Now, that was a very different result than so many of my friends got. Would you care to comment on various forms of prostatectomy and what we're looking at?
Yeah, yeah, of course. I mean, I think the first thing is it's a bit unusual to remove the entire prostate because in the absence of cancer. Usually they remove part of it, and we call that
Look,
TURPs,
maybe I was,
transurethral.
excuse me, maybe I didn't say it correctly. He didn't take the bag, he just
Okay.
took the insides.
Yeah, so he did what we call TURP, which stands for transurethral
Terp.
radical, right, TURP. So he removed part of the prostate because you had enlarged prostate, but there was no known cancer in it. And in general, generally speaking, if there was cancer, God forbid, it's unlikely to do surgery at a particular age because we feel that at that time some form of radiation therapy is okay. So what I'm just not 100% sure though that they found no cancer, and despite this, the doctor gave you radiation.
Well, there's a story behind the no cancer. Some years ago, my PSA started to go up, and
Okay.
it went up to about 7. And in the small town I live in, the local oncologist did a DRE, and he found a bump on my prostate. And he said, "Well, I think you have prostate cancer, and I want you to get a biopsy." Now, I had enough friends who went through biopsy that did not sound like a lot of fun. And furthermore, I had concerns about how accurate the needle biopsy was
Yeah.
with regard to finding information on the prostate. So again, I sniffed around and I found out that they had increased the Tesla numbers on the MRI, and they now had a 3 Tesla MRI, and there were a few of them in the United States. And I found one right here at UC Med again with Dr. Shinohara. So I went down, and he did a 3 Tesla MRI on my prostate.
Okay.
And afterwards, he came over to me and he said, "The little bump is a cyst, and you don't have prostate cancer." So that was my diagnosis. There's
Yeah.
a lot more to that story, but we're going to get to it later in the interview.
Yeah. I mean, look, prostate cancer is a cancer of the prostate gland. And there are three ways to manage that. One way is to do nothing. And what we call that is watchful waiting or observation. And the reason for that is because there are many men with prostate cancer who never have any problem with the disease whatsoever. So it's there and it just causes no issues. And if you can watch the disease, and if it starts to cause any trouble, that's when you actually intervene. I think it's a very acceptable approach in certain situations of prostate cancer, not all. In other words, if the PSA is very little, if the Gleason score, which is how the cells look under the microscope, are not too deviated from the normal appearing cells, and if the person just really is worried about the side effects from prostatectomy and other type of therapy. So that is one approach. The second approach is
Oh, the 1
surgery.
second before you go to number 2. When you do watchful waiting, what kind of tests are you running and how frequently to see if there's been some kind of.
Yeah, good question. So it depends, but in general, most often is usually there's a PSA that's usually done twice a year, and they sometime we do also DRE twice a year, and then some form of imaging is often done right now. We usually start with an MRI at the time of diagnosis, so you can look where the cancer is and where it's located in relationship to the prostate. And lastly is really the consideration of repeating a biopsy, because the only way to know the Gleason score is via a biopsy. Now, for your audience, a Gleason score is basically looking at the prostate cells under the microscope and deciding whether these prostate cancer cells are too deviated from the normal cells. That's a high Gleason score, which means they're behaving aggressively, or they're not too deviated, which means they're not behaving aggressively. So that's why you repeat PSA, you repeat DREs, and there are situations where you repeat a biopsy as well. I'm not a big fan of repeating biopsies every single year unless I see really significant changes in the PSA and the Gleason and the exam. But it's pretty hot debate topic in the world of prostate cancer. I've actually done a couple of podcasts on it on my Healthcare Unfiltered because I've always noticed there's some confusion on this. In fact,
One second before you go on.
Mhm.
Your podcast, Healthcare Unfiltered,
Right.
has some programs on prostate cancer. And are the programs archived?
Oh yeah. I mean, they can go to any. It's all over. It's anywhere. There's a podcast on Apple Podcasts on everything.
Okay. That's important
I
for.
just mentioned my highest viewed and listened to episode in 2023. Every year, I usually put a list of my top 10 because I do this weekly. And the top one actually of 2023 was a prostate cancer debate. And basically, I had a professor from University of Chicago and a professor from Johns Hopkins. And the question was, whenever you have a prostate cancer that is called prostate cancer with Gleason 6 disease. Again, Gleason 6 means that the grade of the disease or how the cells look under the microscope is 6 out of 10. Do we consider that cancer or not? And basically, it was a very hot debate. And some folks would say that if we call it cancer, then there's a possibility that folks may want to intervene and do some treatment for it, and it may not cause any trouble. The first thing in medicine your audience needs to know is do no harm. Do no harm. Our goal is whatever we do is we're helping the patient. We're not hurting the patient. And because of this, we need to step back every single time there's a problem and there's a diagnosis. Understand the disease, the diagnosis, but also understand our patient. Understand what the patient's wishes are. There are many examples in the book of stories where I felt my patient should undergo chemotherapy, and my patient said, no, it's not for me. And it bothered me when I knew it was the right medical choice, but I learned from my patients that whatever is the appropriate medical choice for someone may be completely the wrong choice for another. So we have to really realize that, unfortunately, sometimes the answer in medical questions is it depends.
And what can a person do? Their PSA is going up, and they want to be on the lookout for possible prostate cancer, for symptoms, because so far the tests haven't revealed anything. So one thing you mentioned on the colorectal cancer was blood in the stool. What can a person be sort of looking for in terms of possible symptoms in themselves with prostate?
Yeah, sometimes, honestly, there are no symptoms at all.
No symptoms.
Right? Sometimes no symptoms. The PSA is high and the person is feeling well. You just did the PSA came back high. And if that's the case, you just have to discuss with the physician who is treating you and monitoring you whether there's any value of doing something at that time or just sitting tight. There are times where there are symptoms. Usually these symptoms depend on the size of the prostate gland. So if it is too big locally, it could cause urinary retention. You're not able to empty your bladder. There's dribbling and there's, because you're not emptying your bladder, you go to the bathroom nonstop at night and so on.
Yeah.
Unfortunately, if the prostate cancer has gone elsewhere in the body and has metastasized to other organs, then the person could have symptoms related to where the cancer has gone to. If it's gone to the bone, it could cause bone pain. If it's gone to the lungs, it could cause shortness of breath and things of that nature.
Chadi, with this pretty decent screening tactics that you all have for prostate cancer, is the reason men are still dying from prostate cancer because they're not engaging in the screening and then they find out when it's too late? Is that it?
Not necessarily. I'm sure there's a factor in it. Look, I don't want your listeners and viewers and audience to leave this episode thinking that screening is the holy grail,
Ah,
because it's not. I mean, I think there are, like I said, there are trade-offs. Sometimes, I mean, imagine, remember, screening is in someone who is feeling completely fine. You're feeling well. So I'm g- I'm gonna have you do a thought experiment. I take a very healthy and well-appearing man at the age of 68 and do a PSA on that person, and the PSA comes back a little bit elevated, as an example. The person is feeling well. He's great. He's golfing. He has good sexual function. All that stuff. Now you do the PSA. It's elevated, and then the doctor says we're going to take the prostate out. And let's say the patient says, "Fine, let's take it out." And now you take it out, and the person is left with the possibility of incontinence. The person is left with the possibility of sexual dysfunction and things of that nature. So we have to be careful. Screening does not come free of charge. When
uh-huh.
you screen someone who is completely healthy, you could detect cancers that are not destined to cause any trouble. That's what we call overdiagnosis.
Mm-hmm.
And if overdiagnosis leads to overtreatment,
Uh-huh.
then you could cause more harm than benefit.
Yeah.
So I think it is important to always educate the importance of detecting cancers early, but be cognizant and cautious about the trade-offs and the downside and the shortcoming of early detection, because you don't always detect early the cancers that need treatment. Sometimes you detect things that are causing no issue whatsoever. So it's like, in your house, you suddenly hear a noise in the basement, and you go there and there's something in the furnace that's just causing a little bit of a noise. We're like, okay, I'm going to fix it right now. But it may have actually gone for the next 5, 6 years without anything, just with a bit of like a noise every so often, maybe once a week. But you just, I'm going to fix it. I'm going to get rid of it. And now you get rid of it and bring a new furnace. Not only you put a lot of money for the new furnace, but then the new furnace is somehow not functioning properly. And now you call the guy to come back and fix it. And now you're going down a rabbit hole of a new project and new issues that probably did not need to from the get-go. All of these nuances of screening in general are discussed in that book, Screening for Cancer. Is about a 20-page chapter, because I really felt very important. I did not want to make the book about one cancer or another. So this is not a book about prostate cancer or breast cancer or lung cancer. This is a book about cancer as an entity. But for the
Yes.
screening piece, hopefully I'm clarifying to everyone that it's not really black and white. There's a lot of gray in screening.
Mel, I noticed in my lifetime that many of the men that I know who got prostate cancer were given medicine to suppress their testosterone, androgen suppression, which you talk about in your book. And I read about Huggins getting the Nobel Prize for the association between prostate cancer and testosterone, which led to uh, testosterone and hormone suppression as a
Right.
way of treating the cancer. When I looked into Huggins' research, I noticed that the number of subjects that he used was very small. It was hard to tell whether it was
Yeah.
three or four or five.
Yeah.
And so my eyebrow went up because I'm trained to look for such things.
Yeah.
So I started sniffing around, and I found a doctor at Harvard named Abraham Morgentaler, and I communicated with him, and then I interviewed him on this program. And Morgentaler says to me, Huggins said testosterone on prostate cancer is like throwing gasoline on a fire. And I'm saying putting testosterone on cancer is like giving water to a man in the desert. He doesn't drink until he drowns. He drinks until he's sated, and then he doesn't drink anymore. And what I'm saying is, when you give testosterone to a man who has prostate cancer, it will absorb a certain amount of the prostate cancer, of the testosterone, and then it won't absorb anymore. And it will not increase the cancer, nor does it cause cancer. Now, as you know, created quite a controversy in this field. And as best I can tell, there's now sort of a national or international controversy going on. This may be a little too much in the weeds for our listeners, I'm not sure, but there's a controversy going on as to which guy was right. So when I talked to my oncologist about this, and he had many men on hormone suppression, including friends of mine, and I say to him, you think I have prostate cancer, and I'm taking testosterone. Well, I decided to side with Morgenthaler, and I kept taking my testosterone. And whether it was lucky or fortunate, or whether Morgenthaler's theory is correct, I never got prostate cancer.
Yeah, so I think there are two things here. One is giving testosterone in men who don't have prostate cancer and giving testosterone to men who have prostate cancer.
Yes.
So in men who do not have prostate cancer and who are experiencing symptoms from testosterone, low testosterone, such as fatigue issues, just like, you don't have certain abilities, I think giving testosterone appears to be safe and appears to not really increase the risk of developing new prostate cancer. I do think it has to be discussed with the physician, and sometimes maybe doing PSAs more common is not a bad idea. But I think there's enough literature out there that giving testosterone replacement therapy for men who have symptoms of low testosterone and don't have prostate cancer is safe. I think for men with prostate cancer, it is being studied, to my knowledge. I think the theory that you brought up is very plausible, and you're spot on. There's, a lot of times you may not actually have any issues and you'll be able to help. I'm still of the school of thought that I don't know. And then it's not clear to me whether if someone has prostate cancer for sure, so it's not like somebody who doesn't have it, where I feel comfortable giving testosterone. If somebody has prostate cancer for sure, I'm still uncomfortable prescribing testosterone replacement therapy, but it is being studied in certain scenarios. In your situation, you don't have prostate cancer, and you just had enlarged prostate, and that actually was removed, like with the TERP. So I think it's, if you're having symptoms of testosterone deprivation, getting testosterone gel or testosterone patches or injections may not be a bad idea. It actually would make you feel better.
It's a little hard to tell at 85 because the plumbing starts to wear out on its own.
I know. You sound pretty good to me, Richard. I'm not sure about the 85. I don't believe it.
Well, I feel pretty good, but my genital plumbing is definitely wearing out over time, and it's noticeable, as is well known. It's well documented.
Yeah.
And I don't get the same boost from the testosterone that I used to get. We talked some about screening. We've talked about
whatever Richard wants. It's your show.
Okay, fair enough. Cancer is such a big topic in this country and around the world.
Absolutely.
That I don't know that we can give it too much time. And I think what I want to do is just take a second and put your book up on the screen again. Folks, this is the best book I've seen on the topic of cancer. And I don't hawk books. You all know that from watching the show. In fact, I rarely even show the book cover on it. But this is really an important book for all of us. And as you've heard, I myself and my wife are personally involved with this topic. Personally involved. I want to talk a little bit now about melanoma. And I'll tell you a little personal story about melanoma. So I had a little bump on the side of my temple. And I had my doctor look at it, and he froze it. And like he does with my other actinic keratosis, which are the what?
He froze a melanoma. Are you sure?
No, he didn't think it was a melanoma. He thought it was a
Ah,
basal. He thought it was a basal.
got it.
So for you listeners, we have different stages of skin cancer. There's this pre-cancer that's called actinic keratosis, actinic keratosis. There's basal cell, squamous cell, and melanoma. So he's been taking this actinic keratosis off my forehead from sun damage. He thought it was just the same or maybe basal. And for a whole year, he sprayed it every couple of months. At the end of the year, I said, hey, Ken, this thing isn't going away. I think you better cut it out and send it in. So he cut it out and sent it in, and it was a melanoma. And so I went in and I had a surgery with a wonderful surgeon at UC Med, Dr. Jonathan George, and he did a sentinel lympectomy, which you will tell people what it means rather than me. And fortunately, when he went and examined my lymphs, there was no cancer in the lymph. And the excision of the melanoma had clearly gotten to the margins. So I was considered safe. The reason I'm telling you the story is so long really put me at great risk. And so would you please comment for our listeners on various skin cancers and what people might want to do for early detection or to keep an eye on things so it doesn't get to a melanoma stage?
Yeah, look, I think that skin exams is also a form of screening, right? It's just not as fancy because you don't have to do like a colonoscopy or a mammogram or testing. It's just simply you strip down and your doctor takes a look at your skin. I think it is very important to have the skin exam once a year, especially if you are fair skinned. But regardless of race and how dark your skin is, skin exam once a year is important. And that should be done by a healthcare professional. And then you should be, as the individual, you should be very attuned to how your skin looks and look at everything that you see that is unusual. We all have like bumps or like colored stuff on our skin, which is the way it is. I think keep a close eye on anything that you find unusual. And what I mean by that, any lesion that has a shape that appears just not like smooth, anything that grows in size over a period of time, anything that changes in color, so it's like a light brown becomes dark brown, anything that becomes ulcerated, like or bleeding or something like this, you really need to seek medical attention for that. It is very critical. Do not ignore this because it could be the difference between curing something and not curing something. Now, having said that, a lot of these things could be nothing. Like actinic keratosis is really not a cancer. This is just basically hardening of certain areas of the skin. And usually the doctor will freeze these areas because they could progress into some other form of skin cancer. Two things I would say. Number one is there are certain things that we could do to prevent skin cancer. And the best thing that we could do is avoiding sun exposure, avoiding tanning beds, and all of these things. This is very critical. This is in our control. Hopefully, nobody is putting a gun to our head and putting us in a tanning bed salon for the next 2 hours every week. I realize we probably all look nicer if we have a little bit of a tan, but trade-offs. You can look nice now, but you have to pay. But there's a payoff for this later on. Hopefully not, but it does happen. So it's in your control. Don't do it. And number two is there are various forms of skin cancer. We like in medicine to divide them into two categories. One is called the melanoma, and one is called the non-melanoma skin cancer. The non-melanoma skin cancer, these are the basal cell cancers and the squamous cell cancers, and these are look like lesions that sometimes bleed or ulcerate, and they just look abnormal in our skin. And they're usually removed and excised or frozen, and oftentimes there's nothing you need to do. The melanoma is a bit different because it could metastasize. I mean, the other ones could metastasize, just not as common. The melanoma obviously is very important because not only it could not only it could metastasize and go elsewhere, and some people unfortunately could die from it, but we've made so much progress in how we treat melanoma that knowing that the person has melanoma is no longer a fatal diagnosis. The majority of melanoma patients are alive and well at 5 years from diagnosis, and they're doing well. Usually, we excise the melanoma. There should be a surgeon that knows exactly the margin and how deep we can take it out. Depending on the finding of the melanoma, you do a sentinel lymph node, like you mentioned, you check the lymph node situation. And after that, some patients need no treatment at all. Other patients may need to undergo some form of treatment after removing the melanoma. And that varies depending on other features of the melanoma on the molecular level. I think I probably lost all of your audience by being so technical, but
No, I don't think so, Chadi.
hopefully I simplified things.
No, you have simplified things, and you've said one thing that I believe is critical, and I'm going to repeat it and underline it, because no one ever taught me this my entire life. And I've been around hospitals and professionals my entire life. Chadi is saying once a year, get your skin examined. I was never taught to get my skin examined once a year.
Yeah,
I say take him very seriously. This is a very serious issue. And I thank you for that. That's really,
yeah,
so now we have certain things that people need to do that we've talked about today. We've talked about mammogram. We've talked about going to your doctor and saying to your doctor after the mammogram, are there any additional tests that I might want to take? You taught us about that. We talked about the prostate. We talked about this melanoma now and getting a exam every year. With regard to the colon, you heard Chadi say every 3 years or 5 years may be enough. You want to talk to your doctor about it, that maybe I was too extreme with every year. And I understand where he's coming from. In addition to everything else, there's a certain risk with a colonoscopy because
of course,
you could do a perforation, and then
of
you've got
course,
a real problem.
of
So
course.
this is all really, really good advice. Okay, we're going to come to a special time in the program now, and I'll tell you what it is. I'm going to ask you to sit back in your chair and just think about, this is one of your thought experiments. If we ended the interview right now, and then you go about your business, and all of a sudden into your mind comes a couple of things that you wish you would have said. When I come back after you being quiet for a little bit and I come back, I'm going to ask you, did you find any of those things that, oh gosh, I wish I would have said? Okay?
Of
So
course.
please think about that. While I tell you all that we broadcast every week, that the name of the program is Mind, Body, Health, and Politics, that all of our 20 years of programs are archived and open source, which means they're free. You can access them. You'll be able to listen to Dr. Nabhan's interview over and over again in case you miss details, or you'll be able to sit with his book and listen to the interview. In addition, you can go to Amazon if you want and check out any of my books. As some of you know, I've got 4 good books out on psychedelic medicine and 1 out on human sexuality. And I think some of them at least are at least worth a look. So every Tuesday morning, we broadcast a new show at 9 o'clock, but most of you listen on the archive. That's fine. Let's go back now. Did you think of anything you'd like to add?
Yes.
Good.
I want to make sure that your audience realize that this is not a textbook. I know that we were very technical talking about colon cancer, prostate cancer, breast cancer, melanoma. But the book really, in addition to all of this, talks about the journey in totality. There's a lot I put myself in the patient's shoes and I thought, what are the questions that come through the patient's minds? From the first oncology visit to second opinions to clinical trials to, what do I do with the caregiver? Caring for the caregiver is so important. Complementary medicine, alternative medicine, all of these things. So I just want to make sure that to me, the journey of being diagnosed with cancer is more than just one element, which is the period of screening and treatment. We go through a process that goes from point A to point Z. And during that time, there's so many elements that is involved in the cancer journey. And I just want to make sure that folks are aware that all of this is being addressed in the book.
Yes. Are are people typically referred for some kind of psychological counseling when they have various forms of cancer to deal with
Yes,
the emotional
I think
component?
it's very important. It's very important. And I think in one of the chapters I call this the emotional journey of cancer. I think people cope differently with different problems, but physicians sometimes they focus too much on only that aspect of let me get rid of the cancer, treat the cancer, but they should also pay a lot of attention to the mental health of patients, to what goes through their minds, and seek psychological help when needed, because a lot of people will need that. And there are certain types of therapies that we know they're very aggressive and very powerful and very potent. And these types of treatments, before we embark on them, we often ask the patient to see a psychologist to make sure that we believe they're mentally fit to undergo and withstand such a difficult treatment. I've worked always hand in hand with my psychologist and psychiatrist colleagues to make sure that this is addressed. And, I think that not every patient needs that. I think that most patients need that conversation with the oncologist. Then the oncologists need to ask themselves, can I actually do this on my own, or do I need a psychologist help? But I think we should be very generous with this, with the referrals, and make sure that patients get these resources. Because frankly, oncologists are not trained to address all of these issues. We get trained by default because our patients tell us a lot of things, but getting the consultation and the help is always welcome.
I mean, I would think that a woman who loses a breast or a
Oh, yeah.
man who loses his sexual function would benefit greatly from having
You
some
don't even
kind
have
of
to go that far, Richard. Hair loss.
ah
Hair loss could be very
yes.
traumatic experience. I mean, I think we underestimate the certain elements of the journey that could have significant and profound impact on the mental health of a patient. So we need to be attuned for that to that. And when things cannot be addressed easily and just by holding a hand and just talking a little bit, I think the patient should be referred for professional help. And I think that's important. If you have somebody with a broken bone, you send them to the orthopedic surgeon to undergo repair to the bone. So the assumption that this is not needed to be referred is short sighted. I think similar to referring a patient to an orthopedic surgeon when they need help, we should really refer them to a psychologist and or a psychiatrist when they need mental help.
One thing I'm going to end with, because I was deeply moved by reading in your book. I felt like I'd met a kindred spirit when you wrote in your book, the best treatment I know for fatigue, if you're getting fatigue following radiation or some of this other treatment, is exercise.
Yep,
And I'm 100% in agreement with you. I was
I
so
know.
happy. I was
Yeah,
so happy to read that in your book.
yeah. I mean, we have to, and I know it sounds strange, weird, but that's the way it is. I mean,
That's
frankly,
the way it is.
and exercise. I mean, again, I mentioned that in the book. I'm not saying go run a marathon or go hiking. Walk. Just get out and walk. That is,
Yeah.
I'll be okay with that. And listen to your body. Sometimes you can walk 30 minutes and you're fine. Sometimes an hour. Follow your body with what your body tells you. But there's no question that if you're fatigued and tired, the best thing you could do is get off the couch and move.
that is a great way to end this interview. Chadi, thank you so much for being with me today on Mind, Body, Health, and Politics. It's been a privilege.
It's such a pleasure, and I'm glad we avoided politics with this,
We can talk about that off the air.
That's next time.
My listeners don't like it when I get into that.
Thank you so much for having me.
You're welcome. And thank you all, gentle listeners, for being with us today on this internet radio broadcast of Mind, Body, Health, and Politics. Until next time, this is Dr. Richard Lewis Miller reminding you that good health is worth fighting for, and it's essential for life, liberty, and the pursuit of happiness.